Hey everyone, welcome back to Medfoxes. This is part 2 of our discussion on hemodynamics of device therapy in the cardiac pacemakers, a beginner's guide series. In this part, I'll be starting with the effects of atrioventricular interval. So let's dive right in.
Effects of AV interval. The presence of consistent AV relationship does not assure optimal hemodynamic as described. Some relationships are detrimental as with 1:1 VA conduction. Similarly, inappropriately short or long AV delay can be detrimental. An excessively long AV delay may inadequately fill the ventricle by causing early mitral valve closure and truncating diastolic filling time. In addition, diastolic AV valve regurgitation may occur with reopening of the valve before ventricular systole. An excessively short AV delay may limit active filling of the ventricle and promote systolic AV valve regurgitation as ventricular contraction begins while the AV valves are still open. It appears that at rest 125 to 200 milliseconds is generally the optimal range if the right atrium and right ventricle are paced. On the other hand, more precise optimization may be possible, although it may vary from patient to patient and from time to time in specific patients. In addition, with conventional right heart pacing, the activation sequence of left side chambers may be quite different from the programmed value due to marked interatrial and interventricular conduction delay. Usually, Doppler echocardiography is used to optimize the AV interval by assessing the pattern of early and late diastolic mitral valve flow and the aortic flow velocity integral. When AV interval can be optimized at rest, assessing the adequacy of this parameter in upright and during exercise presents greater technical difficulties. There is some predictability in certain aspects of AV interval optimization. It is consistent that optimal hemodynamics at higher heart rate require short AV delay than are optimal at lower rate. With exercise, there is a relatively linear decrease in the normal PR interval as exercise increases from the resting state to near maximal exertion. The total reduction in spontaneous PR interval in normal individuals appears to be about 20 to 50 milliseconds or approximately 4 milliseconds for each 10 beats increment in heart rate. Sophisticated pacing systems have already been developed that incorporate these concepts. It appears that cardiac output can be more effectively increased and pulmonary capillary wedge pressure, presumably an atrial pressure, can be effectively maintained at lower levels using variable AV interval rather than fixed AV intervals. Let's discuss about atrial sensed versus atrial paced AV intervals. Hemodynamics involves the difference in the appropriate AV intervals, depending on whether the atrium is sensed or paced. If atrial activity is sensed, This makes the initiation of the pacemaker AV interval because some atrial activation has already occurred at this time. The AV interval based on sensed atrial activity should be shorter than when the atrium is spaced to begin both the AV interval and atrial electrical activation. The appropriate difference in the atrial sensed AV interval setting and the atrial paced AV interval setting is probably variable in different patients. The most appropriate value for these parameters are somewhat empirically determined. Generally, an atrial sensed AV interval is 20 to 50 milliseconds less than the atrial paced AV intervals. Let's discuss about hemodynamics of alternative site right ventricular pacing. Pacing from the right ventricular outflow tract offers the theoretical advantage of more normal electrocardiographic vector of ventricular activation due to basal to apical conduction and earlier activation of bundle of His. The clinical benefits of RVOT pacing have been difficult to demonstrate. Some studies have found significant acute hemodynamic advantages. However, several randomized controlled chronic studies have demonstrated either modest or negligible benefits to RVOT or multi-site right ventricular pacing compared to right ventricular apical pacing. These studies did not fully examine the role of patient selection for such factors as presence of atrial fibrillation, type and degree of heart failure, interventricular conduction delay, degree of mitral regurgitation, and diastolic dysfunction, which may influence the response to pacing. Right ventricular septal pacing has been has also been examined in small clinical studies. Several studies have suggested acute hemodynamic benefits of right ventricular septal pacing in patients with reduced left ventricular function, presumably due to a shorter activation time between the septum and left ventricle during right ventricular septal pacing compared to other right ventricular sites. However, long-term clinical benefits was not been demonstrated. Detrimental effect of continuous right ventricular pacing. Continuous right ventricular pacing may have detrimental effect on myocardial function and result in progression of heart failure in patient with left ventricular dysfunction. Right ventricular pacing produces an asynchronous pattern of activation, contraction, and relaxation between the left and right ventricles. Experimental studies have shown that chronic RV pacing induces abnormal histological changes, left ventricular hypertrophy or thinning, and subsequent impairment of left ventricular function. In patients with complete AV block and normal ventricular function at the time of permanent lead implantation, chronic right ventricular pacing may induce regional myocardial perfusion defect, wall motion abnormality, and impaired left ventricular systolic and diastolic function. In recent study of patients with sinus node dysfunction, continuous right ventricular apical pacing was associated with an increase in heart failure and atrial fibrillation, even among patients with preserved AV synchrony and normal basal QRS duration. Let's move on to the hemodynamics of pacing in hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy represent a special situation for which pacing may have a role in some patients. These patients have obstruction to left ventricular outflow tract caused by hypertrophy of interventricular septum, typically in subaortic valve area, combined with systolic anterior motion of mitral valve. A number of studies documented that by producing dyssynchrony of left ventricular contraction, dual chamber pacing reduces the degree of outflow tract obstruction and symptoms in many patients. A full understanding of the mechanism responsible for improvements is lacking, and the possible role of pacing in improving diastolic function and mitral regurgitation is still debate. The tracing shows the impact of AV sequential pacing on left ventricular and femoral arterial pressure in selected patients with hypertrophic obstructive cardiomyopathy. This pressure tracing, you can see there is a presence of nearly 150 millimeter mercury pressure gradient at baseline during sinus rhythm in patient with hypertrophic obstructive cardiomyopathy. You can see in this tracing with AV sequential pacing at an interval of 75 milliseconds, the pressure gradient decreases to 50 to 90 millimeter mercury. The beat-to-beat variability of measurement of this gradient is highlighted by the bottom tracing. So this tracing is with AV sequential pacing. You can see the dramatic decrease in the pressure gradient when compared to the pressure gradient in sinus rhythm, which is more than 150 millimeter mercury at least. And here with AV sequential pacing, the gradient is significantly reduced to 30 to 50 millimeter mercury. With this, let's move on to today's last discussion on hemodynamics of left ventricular pacing. There is a growing enthusiasm for biventricular pacing therapy in treating patients who have baseline QRS prolongation and severely depressed left ventricular systolic function. This therapy seeks to optimize left ventricular contraction by narrowing the dysfunctional activation pattern associated with ventricular conduction delays. Numerous acute studies have shown that pacing both ventricles simultaneously is of hemodynamic benefit in patients with QRS prolongation and depressed ejection fraction. Much uncertainty remains about the mechanism by which hemodynamic improvement occurs, but several factors are likely. The first is improvement of atrial left ventricular synchrony to optimize end diastolic filling and reduce diastolic mitral regurgitation. Second is a lengthening of diastolic filling time due to a shortened QRS duration. The third and probably most important factor is resynchronization of severely uncoordinated and dysfunctional pattern of ventricular contraction in patients with prolonged native QRS complex. Biventricular pacing avoids the detrimental effect of right ventricular pacing alone. The demonstration of long-term benefits from biventricular pacing would serve a growing population of patients who have a heart failure and potentially a broad scope of patients who have a left ventricular dysfunction and require antibradycardia ventricular pacing. Biventricular pacing will likely expand in use of patients with chronic atrial fibrillation, particularly those who require AV junction ablation for either heart rate control or treatment of symptoms.
You've just completed another vital step in understanding cardiac pacing. Let's keep the momentum going. We'll be exploring more essential topics in rhythm management devices in the upcoming videos. And now it's your turn to check your progress. Head over to our website where we've built two assessment tools just for you: a knowledge assessment with 500 plus MCQs from the entire Beginner's Guide series, and IBHRE format exam simulation consist of 5 blocks, 40 questions on each block, time to help you sharpen your time management for the real exam. Whether you're studying for IBHRE, CCI, EHRA, or simply want to sharpen your clinical understanding, these assessments are your next step. Click the link in the description to get started now. If you're enjoying this series, like, share, and subscribe to Medfoxes. It really helps us grow and reach more learners. Thanks for watching, and I'll see you in the next one.